Hello, everyone. My name is Justin WORMALD. I am a plastic surgery registrar, a trainee in plastic and reconstructive surgery, and I'm currently doing my PhD at St John's College at the University of Oxford. I also have a teaching role there and teach the medical students about surgery and how to deal with patients who have problems that need operations. But I'm going to be talking to you today about something a little bit different. So I'm going to be talking to you today about what I do as a job, really, and how I got to where I am. And then I'm going to talk a little bit about the kind of research that I do at St John's and why I do it at St John's and why I do it at Oxford. And hopefully I'm going to inspire you to maybe go down a similar path or at least think about some of the things that I'm talking about. So I'm going to share my slides so you can see me. Okay, so there I am in the bottom corner. So as I said, my name is Justin, and my title is really talking about how we can use reconstructive surgery to help patients after trauma. And the idea is that we improve outcomes for patients who've had injuries or had cancer, but we also build the evidence base for these kinds of operations to see which ones work best. So going back to the beginning then, so originally I'm from North London, a place called Muswell Hill, and I grew up there, went to school there, and then I went to a place called University of East Anglia, which is there at the bottom. And it looked like this every day. It was beautifully sunny up in Norwich, and they had these cool buildings called the Ziggurats there. And I lived on the ground floor of one of those for the first year, and then I moved into a house and lived with friends for the rest of my time. And I was there for 6 years. I did my 5-year undergraduate degree, which is called a Bachelor of Medicine, Bachelor of Surgery, MBBS. It's called slightly different things in different places, but it basically means you become a doctor. And quite often people will do an extra year of study, either in a specialty that they're interested in. They'll do an extra little 1-year degree called a BSc, or like me, you can do a master's, which is a higher degree, and you just spend 12 months doing research that you're interested in. You get trained in how to do different types of clinical research or basic science research. So I did that in between my 4th and 5th year in 2012, and I graduated in 2013 with both the MBBS and the MRes from Norwich. I then decided to go back to London and do my junior doctor training there. So 2013, 2014, I was at place called Central Middlesex and Northwick Park hospitals, which you may have heard of. And I did various different jobs there, working as a junior doctor. And then for my 2nd year, I went to St Mary's Hospital in Paddington in West London. And I did 6 months of emergency medicine there in A&E and 6 months of vascular surgery. So that's a surgical specialty where you operate mainly on the blood vessels of the body. So that's really where I learned how to do surgery. My interest in surgery actually started during medical school, and I became interested in reconstructive surgery at that point. I remember being in a clinic where we were dealing with women who'd had mastectomies, had their breast tissue removed for breast cancer. And the clinic was run by a plastic surgeon, and he was seeing patients who wanted to have the breast reconstructed. So he would do an operation where he would take excess sort of fat from the tummy, basically, and then remove that, and then use that to make a new breast. And these women were just so happy with the results of the operation and really restored their quality of life. And that's what really sparked my interest in reconstructive surgery. And it lasted all throughout my medical school and through these early years of training. If you want to become a surgeon, then you have to do another exam once you've completed medical school, and you can do that in the first few years as a junior doctor. And that's called the MRCS, or the Membership of the Royal College of Surgeons of England. It's 2 exams, one's a written paper and one's a kind of practical exam. So I did those 2 during my first 2 years of training, and joined and became a member of the Royal College of Surgeons, which is pictured here. And that's in Lincoln's Inn Fields, which is in London, again in Holborn. So really good museum there. So if you're in the area, it's worth going to have a look. They've got some really cool instruments and different things you can have a look at. I then went on to do my what's called core surgical training. So once you've done your generic bits and pieces of different specialties as a junior, you then sort of start to specialize into either surgery or medicine. So I did various different specialties at Chelsea and Westminster first for a year, including plastic surgery and pediatric surgery. So that's surgery for children. And general surgery is like usually operating on the bowel and that sort of thing. So I did that, and then I did 6 months of plastic surgery at the Royal Free Hospital in North London, which was absolutely amazing. And then I did 6 months of orthopedic surgery at Great Ormond Street Hospital, which again is a children's hospital, which you may have heard of. And again, that's a wonderful place to work and to learn. And really, at that point, I knew I wanted to do plastic surgery, so I applied for a proper training program in plastic surgery. But I also knew I wanted to do research, and that sparked from when I did my master's at medical school. And so I applied for what's called a clinical academic training pathway, where you do 75% of your time, clinical, seeing patients, treating patients, operating on patients. And then you do 25% of your time doing research related to the patients that you see. And so I was lucky enough to secure one of those jobs down in sort of in the Oxford region. And so I went down and started work at Stoke Mandeville, and I did 3 years as a plastic surgeon in Stoke Mandeville as a trainee. After my 3 years there, I then paused my clinical training to do a full-time PhD, or DPhil as it's called, in Oxford. So before I carry on, I think it'd probably be worth clarifying what I mean when I say plastic surgery. So most people, in fact, this is the pictures that I got when I typed in plastic surgery into Google. You get these terrible pictures of celebrities that are kind of addicted to cosmetic surgery, or these funny pictures of drawings on people's faces. And this is very much cosmetic surgery, which often is done by plastic surgeons, but it's a very small part of plastic surgery, actually, particularly in the UK. You don't do any cosmetic surgery really as a trainee. I mean, you have to do a few cases here and there to get your training, but really the most of what you do is trauma and reconstruction. And that real plastic surgery that we do and that we get trained in was pioneered by these two guys who are known as the kind of fathers of plastic surgery. That's Archibald Mackindoe and Harold Gillies. And these guys really pioneered reconstructive surgery during the First and Second World Wars, where men who were flying planes and got either shot down or had malfunction of the plane, because the engine was in the front and the fuel tank was in the front. If they were shot there, the fuel tank would ignite and they would get really bad burns to their upper torso, arms, and faces. And usually they would just end up, probably surviving, being taken back to the UK or whatever, and then they would die in hospital, usually from infection, just having dressings. But actually, Archibald Mackindoe was a super clever guy, and he found ways of performing this kind of surgery using other parts of the body to reconstruct the terrible injuries that they had. And actually they survived and managed to get back some quality of life. So these guys are the kind of real pioneers of what I consider to be, and what we generally consider to be, plastic surgery, reconstructive surgery. So these are some pictures of the guys that they operated on, and a few before and after pictures here. Obviously these terrible injuries that they're able to reconstruct using different parts of the body. What we kind of work on, the principle is that there are quite a lot of spare parts in the body that you don't really need, and so we can use these. A bit like I mentioned with the women with breast cancer, they've got a bit of excess tummy fat, then that can be used to recreate a breast. And there's spare parts on your legs, and there's spare parts on your arms, and these can all be used to reconstruct areas if you have a big problem with a big hole in your face like this guy, or a big skin cancer or something, or a big hole in your leg. So that's kind of what plastic surgery and what trauma reconstruction is all about. So these are some more contemporary pictures of what we do as plastic surgeons. So this guy's had a really bad injury to his leg. He's lost a lot of muscle and skin from his leg, probably in a car accident or a motorbike accident, is what we commonly see. And he's had an operation where they've taken this part of skin and fat and muscle from somewhere else in his body, often the back is used, and they've filled the hole with this bit, and he now has managed to keep his leg. Historically, you just have to amputate the leg here, which is really devastating for a young person. But now we can reconstruct using, so this is what's called a free flap, so probably a bit of skin and muscle from his back or his tummy. He's probably had a skin graft here. That's where you just take the skin, and another flap here, or maybe the same flap. This is the breast reconstruction procedure I was talking to you about before. So we take a bit of tissue from the abdomen, and then we can reconstruct the breast here using that, and then they have a scar here. This is a young girl who's had really terrible burns as a child. Often we see these injuries when a child has reached up and pulled down a hot cup of tea or a boiling pan, a pan of boiling water from the hob onto themselves. They get very severe burns, and if they're not treated very quickly, then you can get really, really bad scarring like this. But again, we can use plastic surgery techniques to release this scar tissue and then reconstruct using skin from other parts of the body. Cleft lip and palate is really common worldwide. Again, it's plastic surgeons that repair cleft lip and palates. So recreating smiles, and that's something that's very rewarding to do. And in general, we do lots of pediatric surgery, so surgery for children's hands and faces. This is a picture of a child with an extra digit. This is called congenital hand differences. So when children are born with differences in their hands or feet, and again, we can reconstruct those to make them have a really good function and a normal appearance later in life. So speaking of hands, I mean, what I really discovered during my training was that actually hand surgery, and particularly hand injuries or hand trauma, are some of the most common things that we see as a plastic surgeon when we're training in the UK. And it's just so common that people injure their hands and require surgery. So it's quite hard to get your head around these figures, but in the UK, there are about 5 million people that injure their hand or wrist every year through accidents, falling, fighting, work, whatever. And actually, that means that about 250,000 of those need to have surgery. So there's 250,000 operations performed by surgeons on the hand and wrist in the UK every year. So huge numbers. And that's important, so I want you to remember that. So that was a little sideline into what it means to be a plastic surgeon. I'm here now, so I'm doing my DPhil or my PhD in musculoskeletal sciences, which is just the topic that fitted best with what I wanted to do. And I work really in this department called ENDORMS, which is one of the biggest departments in medical sciences. So the kind of science that is related to medicine and medics and surgery and drugs and that sort of thing. And I'm half based in the Kadoorie Centre, which is at the John Radcliffe Hospital. And it's just above the emergency department in that hospital. And also the Botany Research Centre, which is the kind of the big research area where I work. And they're both up in Eddington, which is a part of Oxford. And this is kind of, I guess, my kind of go-to page about what I do. So the title of my PhD is called Understanding and Preventing Surgical Site Infection Following Surgery for Hand and Wrist Injuries, and I'll talk to you a bit about that. And the reason I do this is because I'm a plastic surgeon, I'm interested in trauma, I'm interested in reconstruction, and I've operated on so many patients with really bad hand and wrist injuries. It's just something that I'm really passionate about and interested in, because these are the patients that I deal with every day. It's super common. And you can imagine, if you look at your own hand and imagine how difficult life would be if you had a really bad injury to your hand and wrist. You can't use your phone, you can't type, you can't open up a webinar like this. There's so many things that you can't do. Difficult to earn a living if you're older, difficult to look after yourself, to cook for yourself, to clean yourself, all those sorts of things. So it's something that actually, although it's so common, people don't think a lot about it, but it is very, very important. All these people down the side here are people that have funded me before for my research and currently fund me. And Hawaii, this little one here, that's the logo for my main research project, which I'll talk to you about in a minute. So I've touched on this, but why hands? Well, I mean, these pictures just show you some of the things that we use our hands for every day. So this guy's eating an oyster. So I don't really like oysters, but if you like oysters, it's pretty important that you've got a hand to eat them with. But in general, whatever you like eating, you need your hands to feed yourself. So that's what that kind of signifies. This lady's, an older lady preparing food for herself, but she could be preparing food for her family. She could be working in a kitchen. Again, with injury to the hand or wrist, it's going to be very difficult to peel those potatoes or whatever it is she's doing. This guy's working with a drill. Maybe that's his job. Maybe he's self-employed. And if he can't work because of a hand injury, then he can't earn a living and he can't pay his rent. So the list goes on. And equally, we use our hands to play the piano, to play computer games, to draw, lots of hobbies that we use our hands for, that we're to play sports, lots of hobbies that we won't be able to do if we have hand or wrist injuries. And therefore, it's actually really important to patients that we can maintain our hand function if we injure them. So these are the sort of things, and I haven't used photos because it's a bit gruesome, and you might be squeamish, so I haven't put real pictures up of the actual injuries. But these are the sort of things I mean when I talk about hand trauma. So we see lots of people chopping their fingers off, various reasons. It's a big operation to try and save those fingers. Lots of operations usually, often have to stay in hospital for quite a long time. We have little tendons in our fingers that mean that we can bend our fingers down and up, and it's really easy to injure them. If you cut your hand here, or on the back, you can see your tendons on the back quite easily. If you look at my hand, look at your own hand, these are the tendons there, those lines going up. You can't see the ones on the bottom because they're covered with the kind of fat on your palm. But yeah, if you injure one of these, it's bad news. It's a 2 or 3 hour operation, especially for the ones on the underside. And it takes about 3 months to recover from that injury to get your hand function back. And then we also see lots of bigger injuries, cuts to the big nerves or blood vessels in the, ever felt your pulse in your wrist? If you cut that there, you can lose a lot of blood. But the nerves that control the power in your hand are really close there as well. So if you cut the artery, it's often the case that you've cut the nerve as well, and we need to repair those. And again, if they're not repaired or dealt with quickly, then you completely lose function of your hand, or sometimes in the worst case, you lose your hand. And if that's your dominant hand, that's bad news. Even if it's your non-dominant hand, it's bad news. We also deal with, although most broken bones are dealt with people called orthopedic surgeons, we actually do deal with broken bones in the hand and wrist as well. And that's because they're a little bit smaller, a little bit more delicate. So it's like doing sort of Meccano, little tiny plates and screws to fix these bones so that you can get your hand function back to normal. And then, this is a really common injury, a broken wrist that we often see in older ladies who have osteoporosis or weaker bones. So it's really a kind of spectrum of things from, what I call soft tissue injuries to the skin, muscle, nerves, arteries, and then injuries to the bone as well. Problem is, all of these things do need surgery, and surgery has risks. And one of the big risks of surgery is that the wound that we operate, we have to create a wound to get down to the structures that are injured. That wound can get infected. So that means that bacteria get into the wound and they multiply, and they kind of overtake your own skin cells or whatever, and they set up camp there and just cause loads of destruction. And if you get an infection in the skin on your tummy, there's lots of fat and muscle there before you get to anything serious. But if you look at your hand, there's not much there. So there's skin, tiny bit of fat, and then you're right down into the important structures like the nerves and the tendons. And therefore, if you get an infection, it quickly destroys all of those really important structures that we've been talking about in your hand. So hand wound infection also is really important. And what we call surgical site infection is an infection that happens at the place where you operated on. And it kind of makes sense, surgical site infection. And these are all pictures of kind of surgical site infections, so a bit gruesome. But I just want to show you that these are really important. During my training, you operate on patients, you look after patients, you often find that you ask yourself questions about the best way to manage the patients. What's the best operation? What's the best dressing? Should we be giving the patient antibiotics? And so you might go and look at the medical literature, the science behind what you're doing, and look for answers there based on people who've done scientific studies to work out what's best. Unfortunately, for example, I got interested in hand wound infection, and I had a look, and really there was very, very little science to guide what we do. We just did basically what we thought was right. We don't really know what's the best way to prevent infection in wounds after hand and wrist trauma surgery. And it's so common, and it's 250,000 operations a year, and probably something like a 5 or 10% infection rate. It's a huge number of patients that get infections after surgery, and we don't know how to best manage them. And really that's what triggered my interest in this particular question, about whether we can better understand which patients get infections and why, and actually can we prevent them. One way that we might be able to prevent infections is by these things. So these were invented by a company called Ethicon, who makes surgical sutures, and they are owned by Johnson & Johnson, and they created these stitches, so surgical stitches, which we call sutures. It's a medical word for stitches. And the traditional suture is just made of, a kind of material that either absorbs or it sticks around, depending on what you need it for. And, some stitches you want them to dissolve over time, some you want to remove yourself when you know it's the right time. Most of the time we use stitches that dissolve. But what we do know about stitches is that the bacteria really like stitches, and they like sticking to stitches, and they can use them as a little bit of a base to then multiply on and cause a wound infection. So the guys at Johnson & Johnson developed a type of suture or stitch that's coated in a chemical which is called triclosan, and triclosan kills bacteria, and it means that they basically the bacteria can't stick to the stitch, to the suture, so they can't use it as a base. And even more than that, if these stitches are coated in triclosan, they actually cause bacteria to die even around them. So this is like what the stitch looked like before. Then we spray some bacteria on, and you can see that the stitch itself's got no bacteria. Even the area around it doesn't have any bacteria. So it's quite cool. It looks quite good anyway. And this stitch has been tested in lots of different operations, but it's never been tested in trauma surgery, and it's never been tested in hand surgery. And the reason that's important is because with trauma, you often are out and about, you're at work, or you're on a football pitch or something like that, or you're outside a bar having a fight, and you cut your hand open, and that's automatically a dirty wound because you're out in the environment. It's not in a really clean, sterile operating theatre. So traumatic wounds are actually probably more at risk of infection than other wounds. But these sutures have never been tested to see if they reduce wound infection in trauma. The other thing about hand surgery is that generally, apart from their injury, the hand or wrist, people are pretty well. They don't have lots of heart problems or lung problems, or they don't have cancer. All the people that these stitches have been tested on generally have been people who are having major surgery for something that's really, really wrong with them. So they're kind of at-risk patients. So you can start to see that although these stitches might work in some populations, we really probably should test them in trauma surgery and hand surgery. And that was my plan. So this is what it all comes down to, really. And these are some interesting papers that if you're interested in medicine or medical sciences, it'd be worth reading. I've got the citations there. If you just Google this, it'll come up. There was this guy called Doug Altman who wrote this paper. He was this absolute hero, absolute legend of medical science research, basically. He was actually a statistician. He worked in Oxford. And he wrote this paper in 1994 saying, basically, the state of the world is that we just do not have any good science or any good evidence for many of the things that we do in medicine. A lot of the decisions we make, which are life and death in lots of situations, there is no good science to back up what we do. And this has to change. People were doing research, but they were doing it so badly, or they were, doing it slightly dodgily. Basically, the results that were done of the existing research weren't really reliable, and we couldn't use that research to make decisions. And so his statement was, we need less research, but we need better research, and it has to be done for the right reasons. And the right reasons are, things that are going to make things better for patients, going to give patients better outcomes. And from now on, I'm going to talk about something called evidence-based medicine. And this is a big concept. And this is the kind of real concept I want you to kind of take away from this talk. And it sounds kind of obvious that we should have evidence for the decisions we make in medicine. But as Doug Altman said in this paper, it's backed up by another guy who kind of wrote again in 2014, 20 years later, basically saying it's still a real problem. So there hasn't been that much progress. So we need better research so that we can actually start making decisions about patient care with scientific evidence, with a scientific evidence base. So going back to my area, hand and wrist injury, trauma surgery, there are 250,000 operations in the UK a year. We think probably about 5 or 10% of those people get wound infections, and there's no evidence to say how we should make that better. There's no evidence to say we should be using sutures coated in triclosan. There's no evidence to suggest we should be using antibiotics or not. There's no evidence to suggest, we should be using one dressing or a different type of dressing. But that's got to change. And my whole PhD is really about learning the skills to be at least one guy who can hopefully make a bit of a difference and build the evidence base for my specialty. I have to say it is a spectrum. And if you look at something like cardiology or which is looking after the heart, or oncology, which is cancer, actually there's quite a lot of really good studies now after the last 30 years that there's been a real improvement in the type of research that's done, and there therefore are beginning to be some answers, and the evidence base is growing for some specialties. And that's why if you're a medic and you have a question, you've got this fully stocked shelf of research, of medical literature you can go to find your answer. There's still work to be done, but it's pretty good. If you're a surgeon, then you start to see that actually a lot of the shelves are empty. There are a lot of things that aren't answered. Some are, and it's getting better. These shelves are getting better stocked year on year. But again, it depends on specialty. And if you look at my area, so hand surgery or plastic surgery, really it's bad. There's not much evidence for what we do, but it's changing. And it's an exciting place to be because there's lots of work to be done. It all really, when you're thinking about interventional research, so I want to test which antibiotic is better for reducing infection or which operation is best for restoring function after an injury, it all really stems down to something called clinical trials, and particularly randomized clinical trials or randomized controlled trials. These are always shortened to RCTs. And they work on this premise. So you have a population. So let's say I want to look at adult patients who have had a heart attack. And I want to know, and there's two drugs. There's an old drug and there's a new drug. And the old drug, we give them to try and prolong their life. But there's a new drug which says it's better. And we want to test which one is actually better. So what we do is we get our adults with who've had a heart attack. Let's say we need 500 adults who've had a heart attack. They're all similar. So we're saying, they're all over 18. They've all had a heart attack. They all don't have diabetes. They all don't smoke, for example. These are just examples, but they're all relatively similar. But of course, there's going to be inherent differences in people, right? No one is the same. That's the great thing about humans. So there is going to be a little bit of variation. And this dice is what it's all about. This is called randomization, and it literally is what it says in the tin. So I get my patient and I put their details into my computer and I say randomize, and it will tell me which one to give them, the new treatment or the old treatment. The patient won't know which one they're going to get. That's really important. And oftentimes I won't know as the doctor either. It'll be done at a different place. The drugs will look exactly the same. So it's called blinding. So any people that will know will be the people who are running the study. The people who are on the ground, the patients giving the drugs won't know. We follow them up 6 months and we see which ones are still alive. That's called a randomized clinical trial or randomized controlled trial. The randomization is important for a number of reasons. Because of how it works, if you randomize a group of 500 patients into 250 in group 1 and 250 in group 2, all the inherent differences between them will be balanced out between the two groups. So actually, yeah, they'll both be different, but they'll be equally different. That might be difficult to get your head around, but basically it means that they're comparable. And the only difference between them is which drug they've got through the randomization. And that's really important because when you come to look at the outcome, you can say group 1 were the same as group 2. They were the same and they're also equally different. And the only difference between them was that they had the drug, and this is how it worked. And these guys live for 50% longer than these guys. The other reason it's super important is that it means that we have no control. And doctors, we know this, doctors and other healthcare professionals find it very difficult to do these kinds of studies without randomization. You think, yeah, but I really think this patient's going to do better with this drug, so I'll give them that one. I won't randomize them. And that's called selection bias. That's having control over this process. And that will automatically affect the outcome because you're going to make the groups different, and therefore they're going to have different results, not because of the drug, but because of the fact that they were different right back here when they were selected and put into the system. And you might say, well, I know, I'm there, and I'm like, well, I know this study's going on, but actually I know that older patients do better with the new drug because that's what the drug company told me. So I'm going to make sure that all the old patients go into group 1 and all the young patients go into group 2, and it's going to show a difference. That's not because of the drug. That's because I put older patients in this group and younger patients in this group. So I can't be sure that any difference is down to what they've got if there's a complication in the fact that the doctor has changed who goes into which group, or the researcher has changed what goes into which group. So these concepts are really, really critical to understand when you're thinking about randomized controlled trials or randomized clinical trials in medical sciences. So there's a little link there, so you can go and have a look at that paper, or just Google randomized controlled trials and their principles. And if you start getting your head around that, you can understand this process of randomization and why it's so important. As I said before, we're way behind in surgery. So I gave you a cardiac, a heart-related example. Historically, it's been very difficult for surgeons to do this kind of research. And that's because you're doing the operation as an individual. I'm doing the operation on the person. Therefore, it's an individual treatment. It's not a little pill that's been created in a pharmaceutical company factory that I'm giving. It's me doing it, and therefore surgeons find it very difficult to do that randomization thing of saying, no, I'm going to be really, really good about this. You can have either one of them, even though I don't believe that if someone else does it, they'll get as good a result compared to if I do it. But as I said, things are changing. We're finding ways around it. These are two quite interesting papers that discuss the problems with surgery. It's also very difficult to blind someone in surgery because they tend to know they've had an operation because they've got a wound and a dressing. So there's all these really interesting issues around surgical research that I'm looking at in my study as well. So this is an example of my study. So I've got my patients, adults with injuries to their hand. I'm randomizing them completely at random to either getting the special stitches with that chemical that kills bacteria, or the normal stitches that we use every day. I'm following them up at 30 days, 90 days, and 6 months to see if they get a wound infection. And I'll be able to tell from that whether these stitches are useful or not, and particularly whether they're useful and whether they're worth spending money on, because they're more expensive. And when you work in the NHS, money is an important thing. We've only got taxpayers' money. We always have a deficit, and therefore we should be using interventions or treatments or operations that actually really help and are cost effective. So this is kind of just going back to Doug Altman, really. So this is the guy that said we need less research but best research. This is the kind of hero. It goes back to why I do what I do for my PhD, which is to maximize the benefit to society, not just to do research but to do it well. And it's actually quite easy to do research badly in medicine, and it has been done like that for the last 100 years. But things are changing, and particularly in surgery, things are really improving, and it's a really exciting place to be. So I'm going to just plug this. So I have this group called the Reconstructive Surgery Trials Network. We're all junior doctors who are interested in surgery, reconstructive surgery, and we're interested in clinical research and the things that we've talked about today. So if you'd like to know a little bit more, you can go to our website and have a look, reconstructivesurgerytrials.net. But actually, I think the most useful thing, if you want to hear a bit more about this and from some different people, have a look at our podcast, which is just freely available on Spotify. If you just search for Surgeons on Trial, then you'll find a load of different podcasts about different aspects of clinical research in surgery, and lots of different types of studies, and all done by trainees for trainees. So it's all kind of young junior doctors who are talking about their experiences. So hopefully that you might find that useful. But I'll finish there. So I hope you found that kind of interesting. I mean, I wanted to talk to you a bit about, why I do what I do. So I'm a surgeon, but I'm interested in improving outcomes for patients. And the way that I do that is by building the evidence base for my specialty, which is trauma and reconstruction. And that's why I came to St. John's and came to Oxford. So Oxford is the hub of surgical research, particularly in plastic surgery. And particularly in terms of doing these clinical trials that I'm talking to you about. So the expertise was here, which is why I came. And it's really a fantastic place to do trials. And there's a huge track record. So the guy who looks after me on my PhD is a guy called Professor Matt Costa. Really nice guy. He's an orthopedic surgeon, not a plastic surgeon. So he does deal mostly with broken bones, particularly broken hips. But he's done huge trials of different treatments for things like hip fracture. And he's really generated massive amounts of evidence in an area where we really didn't know what we were doing, and really pushing the frontier in surgery, and catching up with our medical colleagues who know all about their pills that they give. So I'll finish there, but I hope you found that useful, and wish you all the best with your exams, and thanks.